Hi, today's topic is male reproductive system part 2. Let us discuss this topic under the following headings: introduction, endocrine functions of testes, control of testicular functions, and the applied aspects. As we have discussed the spermatogenetic function of the male reproductive organ in our previous class, today we are going to discuss about the endocrine functions of the testes. So the Lighting cells of the testes produce the male sex hormones, which is known as the androgens. The major androgens are testosterone, androstenedione, and dihydrotestosterone. The satellite cells of the testes, they secrete the estrogen, inhibin, and also the actin. The most important testicular hormone is testosterone. The endocrinal functions of the testes, they mainly depends on the testosterone. Testis descends and it passes out of the abdominal cavity and it reaches the scrotum through the spermatic cord. This is how the testis descends. Testosterone is a steroid hormone secreted by the Leydig cells. Leydig cells are located in the interstitial connective tissue between the seminiferous tubules. Lighting cells are numerous in newborn male infants and also in the adult males. So the androgens are secreted in infancy and also after the puberty. In childhood, lighting cells are scanty, almost they don't exist. So during the childhood, practically no testosterone is secreted from the testes until the age of 10 to 12 years of age. The androgen secretion starts declining after 40 years and becomes almost zero by the age of 80 years of age. But not every male, in every male, the testosterone level decreases after 80 years of age. The normal man secretes 4 to 9 milligrams of testosterone daily. The plasma testosterone level in adult males is 0.65 microgram percentage. Derivatives of testosterone. Testosterone, with the help of aromatase enzyme, gets converted into estradiol, the major female sex hormone, and the testosterone, with the help of 5-alpha reductase, it also gets converted into 5-alpha dihydrotestosterone. Transport transport of testosterone in the plasma. Only 2% is in free form. This free form alone is physiologically active in the target tissues. 98% is found in bond form, which is bonded to the plasma proteins. 68% is bound to albumin, and 30% is bound to testosterone binding globulin, which is also called as sex steroid binding globulin or gonadal steroid binding globulin. Androstenedione is an important steroid precursor for blood estrogen in men. So it is secreted by the testes at a rate of about 2.5 milligram per day. It is very important that the major portions of the blood estradiol and estrone in normal men are derived from blood testosterone and androstenedione. Only a small amount of estradiol is secreted by the Sertoli cells or and the Leydig cells of the testis itself. This is in men. And dihydrotestosterone or DHT, so it's another important androgen which is present in the blood. Testosterone is converted into dihydrotestosterone by the enzyme 5-alpha reductase. So only 20% of the plasma dihydrotestosterone is formed from the testis, either by as the 5-alpha reductase from the Sertoli cells and testosterone from the Leydig cells. And about 80% of the dihydrotestosterone is derived from the peripheral conversion of testosterone. In the target tissues, the testosterone is converted into the dihydrotestosterone. So this dihydrotestosterone has more than twice the biological activity of the testosterone. Let us discuss the synthesis of androgen in the testis. The androgens are synthesized in the Leydig cells from the cholesterol. The key step in the synthesis of androgen is the conversion of cholesterol to the pregnenolone, and this is the rate limiting step. Pregnenolone gets converted into progesterone, and progesterone gets converted into androstenedione. So androstenedione gets converted into testosterone, and pregnenolone also gets converted into 17-alpha hydroxypregnenolone, and then DIHYDROTESTOSTERONE, that is dihydroxyepiandrosterone, and that gets converted into androstenedione. So androstenedione again gets converted into testosterone. So testosterone in the testis, with the help of the enzyme 5-alpha reductase, gets converted into dihydrotestosterone, and in the tissue also it gets converted into dihydrotestosterone. So 80% of the dihydrotestosterone gets converted in the tissues, and only 20% that the synthesis of dihydrotestosterone happens in the testis. Functions of the testosterone can be discussed under the following headings: the functions of the androgens in the fetal period, that is before birth in utero, the functions of androgens at puberty and in adults. The functions of androgens in the fetal period: the testosterone is secreted by the fetus, the fetal testis, at about the second to fourth month of the embryonic life. So it has effect on the sexual determination in the fetus, gonadal, that is the gonadal sex differentiation, and it plays an important role in the with acting on the Y chromosomes, the testis determining factor, and the Mullerian inhibitory substance, then genital differentiation, that is the internal genitalia, external genitalia, and it also has effect on the descent of testis from abdomen to the testis. Here the dihydrotestosterone plays a major role. If not, it will result on the cryptorchidism. We will discuss that in detail in the applied aspects. Gonadal sex differentiation, which is dependent on the genotype of the embryo. In genetic embryo, that is which has the chromosome 44 and XY, the bipotential gonads, it begins to differentiate into testes at approximately 6th week of the gestation. The Y chromosome plays an key role in the testicular differentiation, whereas in the genetic female, which has the 44 XX chromosome embryo, the bipotential gonads differentiate into ovaries by about 10th week of the gestation in the absence of testis determining factor, which is shortly called as TDF. So the presence of TDF has to be there for the formation of the testis, for the differentiation of testis. If that is not present, so it takes some time, and there comes the formation of ovaries at the 10th week. Genital differentiation. So we have, as we have discussed, the bipotential gonads. That is, the gonad can go either way. So if there is testis determining factor, then it will get converted into testis. If testis determining factor is not present, then it gets converted into a ovary. And if at this time, by this time, the differentiation of the internal genitalia happens. So it will have a pair of Wolffian, that is the male duct, and also a pair of Mullerian duct, which is the female duct. So by about 9th week of gestation, the embryo has both male and female primordial ducts. That is the uh, Wolffian duct is a male duct and Mullerian duct is a female duct. So if there is testosterone secretion by the Leydig cells of the fetus by about 7th week of the intrauterine life, that stimulates the differentiation of the Wolffian duct into the epididymis, vas deferens, and seminal vesicles. If there is no testosterone, the Wolffian duct degenerates and the female sex organs develop from the Mullerian duct. So it is not only the testosterone, the testis also secrete Mullerian inhibitory substance, which is very important for the development of female sex organs from the Mullerian duct. So testis at around the 7th week of intrauterine life, it secretes not only testosterone but also Mullerian inhibitory substance. So this is the genital differentiation which happens at the internal genitalia. The external genitalia also develop from the common thing, which are genital tubercles and genital swelling, genital fold, the urogenital sinus. So for the differentiation here, the dihydrotestosterone produced by the testis in male fetus It stimulates the differentiation of either the male external genitalia or the female genitalia. So by the fifth month of gestation, it is decided. If there is no dihydrotestosterone, then it will get differentiated into female external genitalia. The functions of the androgen at puberty in the male, usually it happens at the age of 10 to 14 years. So it plays an important role in the endocrine growth, physical growth, and also the behavioral growth. So the Leydig cells here, it wakes up and it peaks at this time. Testosterone at puberty effects on the external genitalia. Testosterone causes the pubertal enlargement of the penis with or without the dihydrotestosterone. Dihydrotestosterone promotes the growth. The scrotum increases in size and it becomes pigmented. Rugal folds appear in the scrotal skin. Effect on the accessory sex organs. So here the testosterone causes the enlargement of the seminal vesicles, and dihydrotestosterone promotes the growth of prostate and stimulates the prostatic secretions. Male secondary sexual characters: body hair. The dihydrotestosterone stimulates the hair follicles and produces a male pattern of hair growth, which is characterized by the beard growth, diamond shaped pubic hair growth in relatively large amount of body hair, and recession of the temporal hairline, so which is in some males culminates in baldness. Voice: testosterone causes the enlargement of the larynx and thickening of the vocal cords, which results in a deeper low pitched voice, so characteristically masculine voice. Muscle mass in the shoulder girdle. Testosterone causes the enlargement of the muscle mass, especially at the shoulder and the pectoral muscles during puberty. Changes in the skin. So skin becomes thicker all over the body. The dihydrotestosterone increases the production of sebum by the sebaceous gland, and it also causes the development of the acne, especially during the puberty. Effect on the psyche, the psychological differentiation. Here there is a brief exposure of fetal hypothalamus to the androgens. So during early embryonic period, it causes the male pattern of sexual behavior during the puberty. It occurs due to the constant secretion of pituitary gonadotropins. So this is where there comes a term called as male hypothalamus. The behavioral changes occurs from the puberty. So the exposure of the androgen makes the difference here. And libido: during puberty, the testosterone initiates sexual drive, that is the libido, and the erectile functions, the potency. And in the aggression, testosterone produces aggressive behavior, and also it brings the interest in the opposite sex. Anabolic and general growth promoting effect. So testosterone causes nitrogen retention in the body. So there will be positive nitrogen balance and causes increased synthesis and decreased breakdown of the tissue proteins, which results in the growth of the body, and skeletal muscle mass increases. So the muscle mass increases at puberty is one of the important feature of the male, right? So this action of the testosterone leads to the misuse of the synthetic androgen in the athletes and bodybuilders to simply improve their muscle mass. Then bone growth, androgens they interact with the growth hormone to increase the spermatogenesis C. So this increases the rate of linear growth of the bones, causing a rapid increase in the stature at puberty. So that's why during the puberty suddenly there will be an increase in the height of the individual. The pubertal growth spurt happens at puberty because of the spermatogenesis C level that interacts with the androgen. So there is a considerable deposition of calciums in the bones. So it is not only that the bone increases in the length, it also becomes thicker. So testosterone causes broadening of the shoulders. It has a specific effect on the pelvis, causing narrowing of the pelvic output, lengthening of the pelvis. So this pelvis in males is different from the females, right? In females, the pelvis is broad and ovoid. So testosterone it causes the narrowing of the pelvis. So testosterone also causes the early fusion of the epiphysis in the long bones. So putting an end to any further growth in the height. So if testes are removed before puberty, the height of the person can get increased. Basal metabolic rate, due to anabolic effects of the testosterone on protein metabolism, the basal metabolic rate is increased. It's increased by about 5 to 10%. Then water and electrolyte balance, the renal retention of calcium, phosphate, sodium, potassium, and water, or other anabolic effects of the testosterone. Testosterone effects in the adults, hair growth, androgenic patterns of hair growth are maintained with increasing age, male baldness may be initiated. So behavioral attitudes and sexual potency are maintained in the post-pubertal adults. Bone loss and osteoporosis are prevented by the androgens in the adult males. Spermatogenesis is maintained in the adulthood by the testosterone along with the FSH. Testosterone by paracrine effect, it diffuses into the seminiferous tubules and act on both the Sertoli cells and the germ cells, and it maintains the spermatogenesis. It is very important to note that within the seminiferous tubules, the testosterone concentration is very high, and it cannot the such a very high concentration even in the local region cannot be achieved even by the exogenous testosterone therapy. So the lack of spermatogenesis due to pituitary failure therefore cannot be corrected by parenteral testosterone therapy. So natural secretion of testosterone is very high in the seminiferous tubules. For the spermatogenesis to happen naturally, it needs such a very high concentration of testosterone. hematopoiesis. So testosterone stimulates the production of erythropoietin. Also, it has a massive effect on the erythropoiesis. So these account affect the hemoglobin concentration and the red blood cell count in the males, which is higher than the females. So effect on circulating and stored body weight for body fats. Testosterone increases the circulating levels of low density lipoprotein cholesterol and decreases the plasma high density lipoprotein cholesterol. So this testosterone, they favors accumulation of upper body, abdominal and the visceral fat. Regulation of gonadotropin secretion. So androgen, they suppress the GnRH and the LH by negative feedback is largely because as it is a function of the testosterone. Mode of action of the androgens. Testosterone may act as a final hormone or prohormone in the target tissues. In skin and male reproductive tract, the testosterone is converted into dihydrotestosterone by the alpha 5-alpha reductase. Testosterone and dihydrotestosterone, like other steroid hormones, it crosses the cell membrane and it binds with the cytoplasmic androgen receptor to form the hormone receptor complex or receptor hormone complex. So this complex, it moves to the nucleus. Here it is moving. So from the cytoplasm it moves to the nucleus, and there it promotes the greater transcription of mRNA, leading to greater synthesis of proteins in the ribosomes. So the testosterone primarily results in the increased synthesis of specific proteins which is required for the development of accessory sex organs and also the muscular growth. So there are other steroid hormones like androgens which acts by these action. Control of luteinizing hormone and follicular stimulating hormone secretion. Negative feedback. The testosterone secreted by the Leydig cells, it inhibits the LH and the GnRH secretion. It maintains the relatively constant secretion of LH and FSH. So declines testosterone secretion declines gradually in men over 50 years of age. Testosterone gets converted to the dihydrotestosterone, which inhibits the luteinizing hormone. Inhibin inhibits the FSH secretion. Aromatization reaction producing the estradiol in the brain is an essential step for the negative feedback effect. The testosterone and its derivatives are responsible for the initiation and maintenance of body changes during the puberty. It stimulates the growth of the muscles, larynx, and the bone growth until sealing the epiphyseal disc. It promotes the hemoglobin synthesis, actin paracrine fraction, which is responsible for the spermatogenesis. So coming to the hormonal control of the spermatogenesis, formation of primary spermatocytes and the entry into the early prophase in the beginning during the embryonic development. So you can see the spermatogenesis is arrested until the puberty. Only after the secretion of the testosterone, the spermatogenesis is activated. So testosterone is required for the completion of meiosis and the spermatid maturation. So testosterone secrete the paracrine regulators, that is the insulin growth factor 1 and the inhibin, and also the transforming growth factor TGF. FSH necessary in the later stages of the spermatid maturation. Estrogen secretion. Sertoli cell and Leydig cells, they secrete small amount of estradiol. So the receptor is found in the Sertoli cells and the Leydig cells, and also in other accessory organs. It may be responsible for the negative feedback in the brain, sealing of epiphyseal plates, and regulative function in the fertility. The applied aspects: cryptorchidism, extirpation, hypogonadism in males and hypergonadism in males, male infertility, and vasectomy. Cryptorchidism, in Greek it is hidden testis. So in 97% of male newborns, testes are present in the scrotum before the birth. In most of the remainder, testes will be completed. The descent will be completed during the first 3 months of the postnatally. However, in less than 1% of the infants, one or two, one or both the testes fail to descend. This condition may be caused by the decreased production of the androgen from the Leydig cells. So if the testis is undescended, and if it is if the testis is lying more in the lumbar region or in the inguinal canal or in the iliac fossa or in the upper part of the scrotum, so the temperature will not be favoring the process of spermatogenesis. So that will affect the production of mature spermatozoa. So infertility will occur if the testis doesn't descend as early as it can. So it can be treated by either giving either the administration of the testosterone or the gonadotrophic hormone may help the testis to descend, or the surgical correction can also prevent the male sterility. Extirpation, that is the removal of the testis. So before puberty, if the removal of testis happens, it is known as Hypogonadism, which is characterized by the permanent sterility, as there is no testis, so there is no sperm production, underdevelopment of external genitalia, and also the accessory organs, that is, and the penis, scrotum, all underdeveloped. Underdevelopment of secondary sexual characters, hair growth on face, trunk, axilla, there is scanty, voice is high pitched like that of the child due to the underdevelopment of the voice box, muscle marks, shoulder girdle, all as poorly developed female like body configuration. All these things happens if the Extirpation happens before the puberty, and also abnormal bone growth. Hypogonadism in males, absent or deficient testicular hormone due to congenital non-functioning of the testis, underdeveloped testis due to the absence of human chorionic gonadotropin hormone in fetal life, cryptorchidism, so the descent of the testis is affected, extirpation of the testis can cause, and absent of the androgen receptors in the testis. Froehlich syndrome, also known as adipose genital syndrome or hypothalamic onychoidism, it refers to the hypogonadism which occurs due to the hypothalamic disorders, pituitary disorders, or genetic inability of the hypothalamus to secrete the luteinizing hormone, releasing hormone, or the gonadotropin releasing hormone. So here what happens is the hypogonadism is often associated with the abnormal stimulation of feeding center. So the affected person, they overeat, and obesity occurs along with the onychoidism. Hypergonadism in males, it results from excessive secretion of male sex hormones in case of a tumor in the Leydig cells. Occurrence of tumor of Leydig cells is common in prepubertal boys who develop precocious pseudopuberty, which is characterized by rapid growth of musculatures and the bones. The height is less due to early closure of the epiphysis. There is excessive development of sex organs and secondary sexual characters at a very early age. It also secretes the estrogens, which can cause the overgrowth of the breast. So that is the gynecomastia. Infertility in males, that is the infertility of the sperm to fertilize the ovum. So it can be due to the androgen dysfunction with normal sperm count if there is a hypothalamic pituitary defect, Leydig cell defect, or androgen resistance. Then isolated dysfunction of the sperm cell production with normal androgen levels. When there is an infection, congenital deformation of the passage, there is a defect in the tract, the male genital tract, in the male reproductive tract, formation of non-motile or otherwise abnormal sperms. Combined androgen and sperm cell production. So when there is developmental failure such as Klippanther syndrome, abnormal testicular descent, acquired testicular defect due to infections, and also in some systemic diseases like chronic liver failure or kidney failures, failure of deposition of sperms in the female genital tract. So when there is obstruction in the vas deferens, failure of ejaculation during the intercourse, failure of erection during intercourse, and following the vasectomy. Vasectomy, it is a permanent method of sterilization. It is a surgical procedure in which they ligate the spermatic cord. So where the vas deferens is ligated there. The vas deferens is cut and ligated. To summarize the topic, here you can see the GnRH secretion plays an important role in the secretion of the LH and the FSH from the pituitary, from where it acts on the testis. So in the testis, the LH acts on the Leydig cells, and from where the testosterone is secreted. Further, testosterone gets converted into estradiol and the dihydrotestosterone. Here the FSH, it acts on the satellite cells and helps in the process of spermatogenesis. So it also secretes the activin and the inhibin, which gives the positive feedback. Testosterone acts on the voice box, bone in the muscles, the hair growth, the beard, and the excessive secretion of the testosterone also causes the baldness, the muscle growth, and also the genitalia, the external and the internal genitalia during the fetal life, puberty, and also at adult. The testosterone plays a very important role. Books to read: Indukhrana, Guyton and Hall, Guénon, and the GK. Thank you.